We are.
Okay.
All right. Hi there. Hi, everyone.
Hi.
Hi.
So I'm so glad that everyone was able to join us today. My name is Valinda Rutledge. I'm the EVP of Advocacy and Policy for APG. And I'm joined today with my wonderful colleague, Jennifer Padoka, the Senior Vice President of Federal Policy. And Jennifer and I will be interviewing one of our very, very favorite people, Dr. Kavita Patel, who everyone knows you, Kavita. If they haven't known you through all of your wonderful work on Capitol Hill and the White House, they see you all the time on television, CNN, MSNBC. I can't believe how many times I turn on my television and I'm like, that's Kavita. I know her. You do such a wonderful, wonderful job. And I am so thrilled that you consented to be a part of Emerging Trends here. Like before we get started, I just want to tell everybody Emerging Trends is a webinar that Jennifer and I do about every month or every other month, and we choose someone that we think is such a trendsetter in healthcare in the United States, someone that has really made a difference in terms of healthcare. And we, as you notice, we have no slides. It's just a simple conversation with people that Jennifer and I have known for a long time, and we pick their brain in terms of where they think healthcare is going. And of course, with all the changes in healthcare, Kavita was my number one choice for this month. So I reached out and we were able to find a date that worked for her very, very busy schedule. As a background, she has a rich background in health policy. She previously worked at the Brookings Institute in Healthcare Reform. She has also served in the Obama administration as the Director of Policy for the Office of Intergovernmental Affairs and Public Engagement in the White House. And she played a key role in the design of the Affordable Care Act. She has a deep understanding of Capitol Hill from her time spent with Senator Edward Kennedy's staff. She was a part of the senior staff of the Help Committee under his leadership and really helped develop and write key pieces of legislation. She is also a practicing a physician, which always impresses me. She has two small children and still has time to see patients several times a week. And so I so admire her. And Kavita, again, I want to thank you for attending this.
Thank you. Thanks, Belinda. Thanks, Jennifer. Thanks to APG. And when Belinda asked me, I was like, I mean, if I had a crystal ball and I could tell you what's going to happen in healthcare, then, we could retire. So I'm going to try to be as close to doing that without actually, predicting the future. So thank you.
Well, first of all, before I get started, you have such a breadth of experience across all sectors of the
Yeah.
industry, the government, the private, the not-for-profit, and the investor. I just did a high points of it.
Yeah.
Can you tell us a little bit about your journey in healthcare? What made you so passionate in terms of taking a look at Healthcare Transformation Task Force, and a little bit about what you're doing now?
Yeah, sure. Thanks. And I'll be brief because I know that we've got a lot to dive into and thinking about emerging trends in different areas, specialty, primary care, there's so much. So I'll just be the older you get, the longer your bio gets. So it's hard to kind of go through everything. I would say that my life has been one of a combination of serendipity, but also like trying to really just listen to that little voice that tells you to kind of take a path less traveled. I think Belinda, you've done this yourself in your career. It would be nothing's easy, I think, in healthcare, but it would be more comfortable for me to probably have stayed inside of one, a health system or a hospital. And what I had to learn, I think, the hard way is that I really do enjoy this kind of uncharted intersection of clinical work. I call it like policy, and Belinda, we can talk about this. Like now it's also politics because you kind of have to figure out when the political window opens for some of these policy ideas. And so the intersection between clinical work policy And then I think something I didn't have enough of an appreciation of until now, which is I'll call it the business of healthcare. I think we've all been recipients, whether you're a healthcare practitioner like us or whether you're trying to just break into healthcare. People often ask me, like, well, how do you have influence in healthcare? And I think you really need to understand all three. You need to understand like the journey of a clinician. You need to understand kind of what you have to do to sustain that business, even if it's a not-for-profit or a for-profit business. And then you have to understand such a highly regulated field, what the regulatory kind of tailwinds and headwinds are. So I've unintentionally kind of marched through those different phases. And I'm not going to lie, Belinda, like when you're a Democrat, as you read my bio, when
Hmm.
the Democrats are not in power, there's a real kind and just like right now, for example, you really have to think about what is it you're trying to accomplish. And so then you put the politics aside and you think about for me, it's just very easy. It's like, how do we advance patient care? I don't care which party does it. I'm ready just as long as we actually do something positive. And I think we can talk about some of those positive signals that are happening right now. But the notion of going from like clinical medicine to research to policy to media to business, I think that was not something I had had like in a 5-year plan. So I'll get more into any of those sectors that you're interested in, but it's always been because I've seen now how each one of those kind of parts of my life have influenced the other. And then I tell people when I talk to young people, I know both of you do too, when I talk to really young people, I ask them like, what do you value? Like, and I've learned over time, I value working around people I like. I value autonomy to some degree. So being able to kind of pick and choose what I want to work on. And that doesn't come at a young age, but it can if you're intentional. And then the third is that you mentioned my kids, like I want to be able to try to choose when and how I prioritize work. I'm trying to learn to work to live, not to live to work.
Hmm.
And that can be very hard for, I think, my generation. It's
Right.
interesting. It's interesting watching Gen Z. They're not as tied to that. So
Yes. So I'm going to start diving right into healthcare.
yes,
So, Um, how do you think the value-based movement is doing? You were one of the
yeah,
authors of the Affordable Care Act. You and I worked very closely 15, 16 years ago when
yeah,
we were building up CMMI and having some of these programs being launched, Pioneer, MSSP, bundle payments. How do you
yep,
think it's doing? Do you think it's slowing down? And quite frankly, I have some of my physician friends telling me they're going back to fee for service because they're kind
yeah,
of worried about what's going to happen. And these are
yeah,
the people that have been very, very committed to the value
yeah.
movement. So tell me what you think is happening.
Yeah. So a couple of things. I think I don't think value-based care is gone. I by no means. I think value-based care is going through like an evolutionary shift. And I was going to try very hard, Belinda, not to use the letters AI a lot in this hour because it gets overused a lot. But I'm only going to kind of invoke it probably 2 or 3 times. This is one of them. I would say that the analogy between where value-based care is and kind of like if you parallel track the graph of like just the technology that's developing literally before our eyes around generative AI and just various uses of AI, which we've had for decades, to be clear. Artificial intelligence is not new, but the ability to do it cheaper and the ability to scale and do things faster is unprecedented. So I would say that we're at just a different evolution point for value-based care where 20 years ago, when you and I can't believe, like 20
Yeah.
years ago when we were working on these things, it was really crude because we were just thinking about things called accountable care organizations, as you know, or patient-centered medical homes. It was just how do we get the delivery system and the incentives to kind of match each other. Now we've advanced 20 years knowing that, well, lo and behold, Belinda, not all models of value-based care work, right?
Right.
Everybody has cited kind of the articles that talk about that the outcomes don't match necessarily the program. I think we're missing the point though. I think what's missing in some of those evaluations, including the New England Journal evaluation, is that we actually did learn quite a bit. What we learned is that we can change our delivery system. We actually have the ability to tell doctors and nurses and allied health professionals that you need to do things differently. What we might have done is had the incentives not paired with that, but I think now we have this kind of potential that technology can assist however you want to kind of enable that change in the delivery system to match the incentives. How will that translate to what a CMMI today needs to do or a payer? I think that's the hard part, right? So I don't see value-based care is kind of failing. And to your comment about, I also have friends who are physicians. By the way, like you mentioned, investing, I work with a venture capital firm and advise on some of their investments. And one of the trends that we're seeing in just broadly in the investment space is that if you come today, anybody who's on this webinar, if you were to come today with an incredible like business idea PowerPoint, which was all contingent on like, let's say value-based primary care. I'm making this up. Value-based primary care
Right.
in South Texas, where I'm from. So that deck would have gotten treated very differently 10, 15 years ago. Today, in order to have that same company funded, you need to talk about how you're going to attract clinicians into this model, how you're going to use technology differently in this model, and how you're going to be able to give better, like kind of transparency into the outcomes. You can't just say, we're going to control costs and improve quality. People want to see, like, we're going to decrease costs by 2%. And here's why we think we're very confident that we can do it. That's the difference. And I think that you're seeing that many people that's hard. And many people want to just
Right.
stay in fee for service because it's not easy, but it's more predictable. That's what I would
Right.
offer.
Right. Jennifer, you had a couple of questions. And first of all, my colleague Jennifer Padoka, many of you know her, but she is phenomenal. She worked for a decade at MedPAC, so she is absolutely brilliant. So I'm going to turn it over to her for a few questions.
Oh, well, I'm blushing now, but thank you so much, Valinda. And, you know, Kavita, we're really excited to see the new director of the Innovation Center, Abe Sutton. And
Mhm.
every new director, every administration gets to bring their new
Yeah.
outlook
Mhm.
to the way models are being tested. And Abe is joining at a time 15 years in the rearview mirror for the Innovation Center. And each new administration has some degree of focus on being a good steward for the trust fund and ensuring that these models aren't just improving quality, but they're either saving money or at least not increasing funding. And so, in part, because of this new outlook, which happens every time we change administrations,
Mhm.
um, Abe released a new strategic document with 3 new pillars focused on prevention,
Yep.
empowerment, and competition. Along at the same time, he shuffled the deck a little bit. So some of the existing models won't be continuing. We anticipate there's going to be new models.
Yeah.
Um, what have you thought as you've been watching from the outside? As you mentioned, you're not in power now,
Yeah.
but you're watching this happen. What are your thoughts on
Right.
this change?
Yeah, look, I'm pretty excited. Abe, I got a chance to meet him when
Mhm.
the kind of the first Trump administration, and back then, as you remember, Adam Bowler kind of started and Brad Smith at CMMI. I would offer exactly the same sentiments to kind of say that I'm very encouraged that I think there were some nervousness about just abandoning, kind of parts of CMMI and not
Yeah.
replacing it with something that like somehow this would be like, well, we just don't think this is important. I think they sent a pretty clear signal, quite the opposite, that this is what I suspect, and it's in that document that you referenced, Jennifer. I think that there is the key word is going to be mandatory. I think if the past 15 years of CMMI could be described as, choose your own adventure or opt out of the adventure entirely, right? Like really like having models that you entered where there was no downside financially, even in that first years. And then candidly, you could drop out if you really didn't want to take some of the financial risk. That I think is going to change. And I think that signals a shift of we no longer want to operate with just tinkering with different models without having, again, all gets back to like, we need guaranteed results, which is not fair.
Mhm.
I would offer like, when you get back to who does this work, and this is, I think, where I worry the most about who's the workforce that's going to do all of this, because guess what? As Belinda alluded to, it's not like you've got a bunch of, clinicians that are like, I want to do this. So I also think the piece that I haven't seen, and I think that Abe is going to have to thread this needle like every other CMMI director does, is how do you engage the BUCAs and the other payers? This has always been a point of contention. It does not
Mhm.
matter who the politics are, who the administration is. We've tried these efforts. Belinda knows, like with the oncology care model, where we had this kind of, hey, if you can get a private payer to also do an oncology patient-centered medical home and have some of these kinds of measures, then that's great. But the truth is it didn't matter, and it didn't matter what another payer did. You could just, again, completely like have totally separate models or no model. And so I think the critical piece is going to, for Abe, is going to be, you can do this. You can signal this shift. You're going to pare down on models that don't work. You're going to be more aggressive about getting people into a mandatory model. How do we deal with the fact that when I practice medicine, I should not have to think about which payer my patient has? I should just know that I need to do better for all patients. That's going to be the biggest challenge. The government does not have, like, obviously any policy levers to force a private payer to do anything, nor should they. But how do you make it so that it's really hard to avoid kind of having a private payer, participation model that allows for the doctors, the clinicians to do the same thing? And that's, I think, his biggest challenge.
Yeah, that's a really great point. You mentioned wearing different hats, the policy, the politics, the clinical. What would you say, perhaps wearing a little bit more of your clinical hat now, to the physicians and other clinicians who haven't jumped in, who haven't been the pioneers trying out these value-based care models?
Mhm.
Now, value-based care models are going to be a bit different than they were even back when they had the choice and either waited,
Yeah.
or they're younger doctors. What would you
Yeah.
say to these folks who haven't yet dipped their toe in?
I would say so. Something I wish I had even kind of done, which is ironic because I've had a lot of policy exposure, is I would insist on having like some role at the table. So normally when
Mhm.
you are, so I'll give you my own personal example. I was an attributed primary care provider in like an early MSSP in a very large health system in the area. And I mean, I worked on the ACO language and the ACA. Like I know a lot about MS, I know a lot about these programs, but I was just like everybody else. I was a frontline clinician, and I was just getting these emails and getting like these pushes in Epic. And I remember thinking like, this is not going to work because I feel like it's missing, the quality measures are actually not something that we use in the clinical setting as commonly, et cetera. So point being, I wish I had then reached out to the head of our ACO, and it was what I would recommend to either, most of the people that are on this like Zoom are probably leaders themselves. So I would just offer, if you're on the clinician side, try to find a way that you can kind of have a voice that can come in the form of, nowadays with Zoom, it can come in the form of attending like a committee meeting that they usually have, usually on evenings.
Mhm.
Do
Mhm.
that. Or if you're on the leadership side, go out of your way. The keys to success, when you sit back and look at the literature around what made programs successful, it really was this like ground game engagement of clinicians. And Belinda, you remember, and Jennifer, you probably remember from, even I think MedPAC may have done a profile, Crystal Run ACO, like back in the day. This was like one of the early ACOs that we saw these disproportionate savings, and we wondered on like, what is it that you're doing? And I remember going and talking to their clinicians as part of some work we were doing with CMMI. And what was amazing is they just basically said, like, well, we just took department by department, GI, endocrinology, rheumatology, internal medicine, pediatrics, and we said, like, what are some of the most common clinical areas that you feel like your colleagues outside of your department don't really understand well?
Mhm.
The GI docs were like, you know what, we're constantly getting referrals for like abdominal pain and asking us to work them up. But really, here's what we need to teach. And then they would bring pizza in, bring the doctors in, and like just teach. And it
Right.
sounds so simple, but I actually think that's like sometimes we go so far advanced in the
Right.
like actuarial model this and we forget the basics. I would
Mhm.
offer go back to like the brick and like block and tackle basics and get clinicians involved. And then now with like the fact that my medical assistant, someone asked me one day, like, who, you know, how important is a nurse? And I said, our nurse, I never see her, not because she's not important. She's constantly doing like prior auths and she's like in another room and I like never interact with her. My medical assistant is like my lifeline. So I would offer the other key to success is maybe it's actually not the doctors and the nurses that you need to like kind of spend time kind
Mhm.
of training and skill setting. It's actually, you know, LPNs, depending on which environment you're in, or medical assistants or techs
Right.
that would be the most
We
helpful.
we have a
Mhm.
couple of questions that have come in, and I think surrounding sort of what you said that you were talking about. There's, as we know, there's been several articles. There was one in particular from Brad Smith that basically said just about four models
Mhm.
made money
Right,
or impact quality at
right.
CMMI. And so
Yes,
that really led for, I think, the foundation for this administration in particular to look at closing down some of the models. But
right.
you had mentioned that through that, maybe they were not successful from a financial point of view, but we did learn lessons. I guess
Yeah,
my question is some of the lessons we learned with that. Do you, and you mentioned the word mandatory models,
yeah,
do you
yeah,
think some of the lessons we learned through that is that we need more mandatory models? Is that the reason why they didn't have savings? Because they had, people only selected if they thought they were
yeah,
going to make money, which meant
yeah.
they didn't? Or do we
Look,
need more episodic models to engage the specialists? When you looked at that article that talked just about a handful of, models made money, thereby were successful, do you know what I mean? Even if we, from your estimation, what are the fundamental changes we have to make? I mean, in terms of the future.
yeah, I'll give you like I like to stick to things I have very firsthand knowledge of. So let's use oncology care model, which was one of the ones that was not a success. Obviously, they changed and have morphed kind of it's been a struggle. You would think, Belinda and Jennifer, that given our spend in cancer care, as well as missed opportunities in cancer care, that it's a no brainer that we need a better model for oncology, especially given ASP and just the way we pay for drugs, et cetera. Okay, all of that I think is unanimous. Oncology care model had so much like hopes and intentions. And then as you kind of have seen from not just the evaluations and the articles written about it, but just the fact that they abandoned kind of that original model and have kind of evolved it into these episodic cancer care, which now obviously Abe has kind of come in and that's not as high of a priority. I think that one, I would offer that we never understood the clinical nature. Here's what I've learned watching that BPCI, which obviously both of you know
Mhm.
very well. I would offer one thing. It's not just making it mandatory. I do think that's a part of it. I do think that's from a policymaker, and I'm not trying to disrespect Abe, but I think it's a very kind of naive policymaker way to think about it. It's almost a little bit like I would joke, I'm not an economist, but I would joke like, well, it's so much easier for the economists to come in and say trend and medical expense ratio, all of that. But then what it gets back to is you actually have to get back to the clinical nature of what you're trying to control or curb the behavior of. Cancer care is moving so fast that the quality measures and even the risk adjustment models that were used for that initial OCM model were outdated kind of by the time they launched. Why? Because we have multiple ways to subtype certain types of breast cancers that actually confer to very different risk profiles. When you have a moving target like that, and we're seeing this now, by the way, with cell and gene therapy, and there's, as you know, a cell and gene therapy model at CMMI. So we're seeing that exact dynamic. When you have a disease that is dynamic and changing almost by the day, like a new paper will hit and we'll know more about breast cancer tomorrow than I did today. You have to have a dynamic risk adjustment model. So I would actually offer that it wasn't just like we need to make it mandatory and we kind of have these organizations that were through consultants wired to succeed and they didn't because we didn't show the savings, but we also used a fixed and rigid model. I actually think that we made a mistake picking oncology as one of the ones out of the gate. And if I could have kind of gone back in my way back time machine and had more influence, I would have tried to push harder for something around a cardiology model, but discreetly in an area like heart failure or an area where we don't have this dynamicism. So that's like one piece of it. The second piece of it is that in CMMI kind of model design or getting these things through all the clearance processes, we really do need to have like a control population, and we use kind of someone who's not in one of these models as a control population. It can be very hard to kind of match these cohorts. So there's always this question of, did we actually pick the right control population for the benchmarks and financial baselines? I think that's something that we should now, and we don't need to use, I won't invoke those two letters, I would say, but we actually now have technology such that we could even create, Belinda, a completely artificial model. I'm not trying to sound like I'm some sort of like, you know me, I'm not like some 25th century tech genius, but we have a way to construct like almost an artificial data kind of control model. So we could, using the history of claims, do that. And that leads me to my third point. It is time, I don't know how to do it. It is time that we figure out how to get clinical data into kind of what we understand about what's happening. Our dependency on the claims kind of processes, and reluctant organizations, including everyone I've ever worked for, nobody wants to just port over their clinical EMR to CMS or to the federal government, to the FDA, to CDC. But we have done things where we've been able to kind of identify ways to allow clinical data in quantities. And certainly everybody in CMMI models has had to do it, but they've had to do it through these like clunky post hoc registry. It's super labor intensive. We have to figure out how to get over it somehow. And because of encryption, we can do this. Like now we have it. It goes back to what you asked, the first question. We have the technology to do it now.
Jennifer?
I'm inspired by what you just said. There's been a lot of frustration with the landing on just 4 models that have been expanded program wide.
Yeah.
And
Mhm.
I have to pick a point as a data dork from MedPAC. There were 8 additional models that actually could have met the criteria that weren't expanded, but that had either improved savings, improved quality, but that just sort of
That's
didn't go
true.
further.
And I don't know why they didn't. There never was
I
really, yeah, you're right.
Yeah, I know. So I've always hoped that one of the directors would
That's
go
right.
back and tap into these ideas, retest them. But we have this issue that
Mhm.
everyone feels like the hurdles, the statutory criteria are hurdles that we
Yes,
have to get past, that we're
yes,
not getting past. Everyone, I think, at this point is frustrated, right? We
yes,
know
yes.
we know there's things like spillover. We know that we're transforming practice. We know that
Mhm.
there's these other models. So there's stuff out there that's just right
Mhm.
within touch that we're
Mhm.
not getting our arms around. What could we do to
Yeah.
transform? You mentioned tapping into clinical data. What can we do to make sure that we're not letting really promising ideas slip through the cracks because of the way we do our comparison evaluation studies?
I'm really glad you mentioned this, Jennifer, because I completely, you're absolutely right to remind me that there were 8 models, and I'm actually like now I'm kicking myself because I'm thinking like that maybe that's the paper the 3 of us have to do. Like,
Yes.
don't abandon these 8, the forgotten 8, because you're right. And I actually remembered thinking the same thing, thinking, you know what, maybe someone new will come along and they'll take this list and they'll scrub it and give it like a new title, and I'm all for it. So I agree with you. I'll give you a place where I think that we're seeing some of that playing out kind of sort of right now, chronic kidney disease.
Mhm.
There's already been
Yes.
like CKCC, right? Like, so, yeah. See, anyway, so chronic kidney collaborative care model. Anyway, the kidney model, as I call it. There's already been like, I think CMMI put out again at the same time, kind of the evaluation and expectations that this model didn't necessarily meet, kind of expected. I'm paraphrasing just like pages of like the evaluation and kind of some comments. Also, by the way, like on the heels of Reach ACO, similar vein of didn't achieve anywhere near like the savings we expected. So therefore, what are the tools that CMMI has? Of course, it's what you just kind of mentioned and alluded to, Jennifer. There are these crude tools to then change the baseline, like change. There's only so much that you can do if you feel like you need to extract more savings. I think what we need to do is actually instead, all those things are because of statutory, as well as I, having sat on the inside, like I think that the 3 of us have kind of been exposed to OAC, the Office of the Actuaries at CMS. I actually think that what we need to do is have a much more robust actuarial model where we give more credit, even if it doesn't necessarily translate to the financial savings. We need to give much better credit to outcomes. And in kidney disease, that's a great example. that we do this like process measure around kidney disease so that if somebody is not quite at dialysis, but if I chart them out as a doctor, I can see where that trend is going. We know that in this particular model, because of the way we define the episode, we might not see that significant financial progress, but that the fact that I've taken that individual, for me, it's mostly women that I have as patients, and I have prevented her from reaching the need for a transplant, which is now where the industry, we are trying not to talk about dialysis. I'm trying to get people as healthy as possible. And then if they were to need something, find out if transplant is appropriate. If I can save that woman an extra 10 years and an actuary can do this, that's actually I want to be able to almost give them financial credit for that. That does not show up. That does not show up in the baseline savings. I can promise you that because I've done it myself with my own patients. It's not going to show up in a year-to-year model, but it is going to show up. And I think that going back to the comment about politics, I'm actually pleased to see a little bit of this like emphasis on prevention. I'm skeptical, so I have a side eye. I have this like skeptical side eye when I see it. But that's a classic example, Jennifer. It causes MedPAC a lot of it's like very concerning to like say, well, how do I measure? Think about if you're at CBO or anybody, how do I define that I have taken a stage 3 CKD woman and maintained her and kept her at 3? Haven't changed much because she doesn't need to utilize care. So the savings delta is very minimal or not existent. But I actually have statistically prevented her from ever needing dialysis and extended that lifeline by 10 years, which is what we do. And I think that's the question. So
Right.
I've actually been reading. So one of the things I'll encourage participants to do that I've started to do in my later life, I've been reading from other sectors. I've been reading about like carbon energy tax credits. I've been trying to think about things that other industries have done when they've reached these points of like almost cataclysmic, we have no
Mhm.
choice. I
Mhm.
know this is going to sound crazy, but why not bring some of that into this? Why not get a credit for keeping you away from dialysis or
Right.
transplant?
Right.
I know that
Yeah.
that level that's going to cause everybody's like,
Right.
oh my God. But this is where a new administration can kind of just
Right.
do stuff. And then
Yeah.
you can just say,
Right.
we're taking a small subset of a CKCC population that's at state. I'm even just going to make this up. We're going to take like certain, from an actuarial perspective, here are the people that are the most likely to, despite what we're doing, our best intentions, they're the most likely to end up with fistulas and dialysis in 5 years, the risk profile. Why
So,
not? Why
so
not?
So, Kavita, last night I was thinking about something when I was thinking about these questions, is that a recent report came out from the AMA that said in a decade, the number of physicians that are in private practice has
Mhm.
went from 60 to 40%.
I saw
That
that.
is in a decade. That is the
Saw
decade
that.
in which you and I and Jennifer
Yeah.
developed all these models and understanding
Right.
that putting incentives in to support physicians in terms of the transformation.
Yeah,
So, like you think of MIPS and you think of the macro bonus. Well, a lot of the macro bonus,
I know.
the advanced APM bonus
I
goes
know.
to the organization because they're employees. It doesn't go to the individual
The
physician.
doctor.
So
Yeah.
we have developed these programs assuming that
Yeah.
many of these financial incentives or quality
Yeah.
incentives would go
Right.
directly to the physician, and it doesn't anymore. Yet we have not changed the
Right.
models to look at it differently. So
Yeah.
looking at it from the context of now we have 40% of physicians in private practice and dropping. Do you know what I mean? So it wouldn't surprise me in the next couple years, it's down to 30%. Then fundamentally, we have to change the models in terms
Yeah.
of how we engage the physicians. Because it's, for the most part, if they are employees of either healthcare plans or large organizations, the incentives have to be different.
Yep.
Your thoughts
That's
about
right.
that as a practicing
Yeah.
physician?
Yeah, I have so many thoughts, and maybe again, in the theme of as I get older, I just say what I want. I think that if there's a health system hospital executive listening, you absolutely need to think about your primary care workforce differently. And this is going to cause, by the way, these are uncomfortable conversations. They're going to cause class wars because, as much as I like to say, all my physician colleagues, we're all kind of a cohort together. We do get treated differently in primary care compared to some of the different specialties. I will just say, and when I say treat it differently, all you have to do is look at how much a pediatrician is paid on average. And I think pediatricians, I'm an internist, pediatricians in my mind do God's work because they are taking, children are not little adults, they're taking growing humans and they're doing so much to try to prevent, but they have no time, and Medicaid and margins are terrible. So what I would say, two things, Belinda. One, we radically need to kind of think of the primary care workforce not as a red line loss leader, which is how every system I've ever worked in has thought about primary care. But I actually want, this is the spirit of bringing in the business side of things. Think of them as like a venture studio. You're going to invest in them. You're not going to expect a return for a very, very, very long time. Could be 10, 12, 20 years. Livongo, Omada, which went public, those are long-term investments. I think of them as an investment and not something that you're constantly having to feel like you're penny in hand and feeling like that combat. Then use what works from that to expand it to the rest of your workforce. So you're not leaving out my specialty colleagues, but you're just trying to take that unanimously lost line leader in every hospital system. And everybody says the same thing around the boardroom. Everybody says like, well, if we have more primary care, we'll make the money by referring them on up, right? Everyone will come to us for our mammograms on site. And this wrong way to think about it. You need to think about it as a place where you can use everything that we've been talking about, whether it's new tools or, controls and failure. I think that we're so afraid. So then the second observation I have is to fail and fail fast. And nobody's going to give me a job as a CEO if that's my tagline, but I think it's the right tagline to be able to be a leader in today's healthcare system. So if you lead physicians on any level, my only advice to you is to kind of create like an expectation that you're going to try things, but you're not going to do like this. Well, we're going to try it. And then if it doesn't work, we're still going to just keep it around. By the way, that reflects back to Jennifer's comment that we've had these models where some of us are like, people, this is not working. Houston, we have a problem, but we just kind of kept them going. And then we have these 8 models that she's reminding me of where we're like, there was some there. Why did we abandon those? So you got to have a culture of like fail and iterate and fail fast. And so those are 2 things. And then I'm tired. I am burnt out by people talking to me about burnout. Stop talking about burnout. Do something about it. Like, I don't want you to acknowledge like that I have burnout and I'm tired, and that's great. Change the way we do things. And this is, again, I said I would only mention it like 2 or 3 times. What I'm seeing deployed around AI, and it's not just the ambient scribes. I will say this to you. I'm going to give you a statistic that I learned from like kind of the like non-healthcare community. I thought this was startling, Jennifer and Belinda, that so by the time right now, anybody that's born from here on forward, 99% of them are more likely to have stronger relationships with agentic AI than people. That can trouble you. It should. But I think it also shows us that the nature of how we're relating to technology is radically changed, where our concerns and obsession about PHI and HIPAA, nobody seems to care. And so how do we use that technology to make like the lives of the people delivering that care easier? And all I need for a proof point for this is that I know the 3 of us, I can just promise you, none of us like being a healthcare patient. None of us. I hate getting my mammogram. I hate going to the doctor. I am so tired of everyone asking me for the same information over and over. So I, of course, would rather have like agentic AI be my healthcare navigator because they're just much easier to deal with. So I think that that's I'll call it the X surprise element, that we should spend more time and again, treating primary care like that investment rather than that red line that everybody just around the room goes, God, we're never making money in primary care. Like, that's not the right way to think about it.
Yeah. So we're talking about really seismic shifts that have happened over the past decade. The evolution of AI, the decrease in physician-owned practices. At the same time, we've also had this other seismic shift over the past decade where most Medicare beneficiaries are now enrolled in a Medicare Advantage plan. And that looks like it's going to continue to grow even with the pressures there.
Yeah.
So in a way, all of our discussion, all of our planning, all of our problem solving within the Innovation Center and within CMS is so focused on that traditional Medicare population, which is effectively shrinking over time.
Right. Or even if it were getting bigger, to your point, Jennifer, it's just, it is not reflective of the total population, right? Like even if they were to grow, they're still like not, why are we ignoring such a huge part of the population? Right, I agree.
Yeah, it's almost like all the action or a big bulk of the action is happening over there with the enrollees in Medicare Advantage,
Mhm.
which raises its own frustration for those patients and other stakeholders about it being a black box and
Right.
having different rules. But those plans also are coming up with their own solutions. You mentioned the innovation center model shouldn't necessarily be aligning with private payers or vice versa, but those MA plans are coming up with their own solutions. For instance, the
They are.
primary care
Yeah.
shortage.
Yeah.
How do we harness those ideas so that, again, things aren't falling through the cracks, or should we be
Yeah.
harnessing those ideas?
No, we should. We should. And I think that this is actually where I do think because of Abe's, we mentioned like the first go
Mhm.
round in Trump, but maybe like I would say like the bulk of his life in healthcare has been like in the private sector with
Yeah.
companies. So to your point, Jennifer, he's been doing this with like private payers, commercial, kind of that like model that you just described, as well as Medicare. So I think you're exactly right. I think this is where you also have to then read the room, right? Like this is where the politics comes into play. We're talking about a budget bill right now where if you are an MCO, you have no freaking idea. You're just preparing for pain. You're not 100% sure
Mhm.
what that's going to look like, but you're preparing for pain. If you're an MA provider, I'm sure, obviously, I know APG is like so on top of the policy. Like if you're looking at this no up code, I forget the name of the act, but I think it might be no up code act. I
Mhm.
think you're an MA plan and you're like, holy mother, like this could completely take out 100 or 200 billion dollars from our industry if it goes in and gets implemented poorly. So you're not, so reading the room as it is right now, the last thing you're going to be able to do is kind of go into a plan and be like, well, here's these new things we want to do. It gets back to my original comment. Everybody's looking for you to like take your new value-based care model, but what they just want is that predictability. And I think that's where we have to kind of thread the needle. So I would imagine Abe senses that and he's trying to understand like where's the appetite outside of, a traditional Medicare population for some of these areas. I think you can see that CMS in the past has made decisions based on discrete episodes, bundles in orthopedics,
Mhm.
oncology, cell and gene, some of these kidney. I think that we now need to kind of be comfortable with it stitched together and just saying, we're gonna have we can't just do this for just Medicare. We need to understand how to control cost trend, and we're willing to let you figure out how you do it. But we'd like to then subsidize. What I'd like to do is then see plans, including commercial plans, subsidize what a practice needs to do to change the way they do work. The places that have had the most success with multi-payer aspects have been able to do it by standardizing contracts, for example, by standardizing
Mhm.
quality measures. So it goes back to, we're not going to tell you which of the 20 quality measures you need to kind of fulfill, but you have to show us that you're doing this and you have to save us money. And we're even willing to
Mhm.
let you show us what the money, we're willing to, going back to the carbon tax credit idea, we're even willing to kind of suspend a little bit of our actuarial reality, which will make the actuaries hate it, but you're going to have to show us why this is valuable yourselves. We'll give you the tools to do it. I often joked that like a dream of mine was, could every CMMI initiative embed like a skunkworks team? And you may not do it like per practice because of size, but what we really need is what you had at MedPAC, Jennifer, right? Like we need a data scientist. I would now add like a technologist with that because I can take one software engineer across probably
Mhm.
200,000 beneficiaries. And because of AI, that's one software engineer can do the work of like 5 to 7. So I almost
Mhm.
wish so I think that's the shift that needs to happen amongst private payers in conjunction with the public. And again, don't try to, the other problem with CMMI is that we kind of have to do things and we have to do them big. We can't like but we've seen pieces of CMMI do things state by state and kind of do things smaller. I'm a big fan of that. You kind of have to balance it where it's not 1,000 flowers blooming, where we had that in the beginning of CMMI, where it was like, bring all your ideas and we'll try everything. You need some equipoise to it, but I think it's possible. And I think it wouldn't be a crazy idea to embed the skills that people need so that you're as a practice not doing the typical like, well, in order to succeed in CMMI, we're going to have to get these consultants and then we're going to have to get in these data centers and we're going to have to invest in all this. And then you're looking at it, what CFO like wants to do this in this climate? Zero, none of them. So I think you have to have like some ability to a private payer, to a Blues, I'm just making it up, to a Blue to say, we're doing this, we're promising to do all these things, here's what we need from you. And we're willing to like, the Blues just want to make it easy administratively. Their problem isn't that they don't want to do this. It's that if you look at the back office systems of how they have to do it, it's crazy hard to do it for just one practice. So we need to kind of take that complexity out
Right.
for them.
Yeah.
So we've got time for one more question. So the question I have for you, Kavita, is what is the piece of advice that you would give for providers out there that really want to be involved in the value-based care transformation movement, but either because they're part of a larger system that's not committed to it, or they lack the resources, or they're burnt out? Just
Yeah.
give us a piece of advice
Yeah.
looking for the future.
I'm going to say this in all sincerity because I've thought about it, Melinda. I think look at the number of virtual options that have been popping up. I think that if I can say this, and trust me, you knew me during the depths of COVID, like every day, it was like a black, dark day. The one small, like silver lining to COVID had been this like openness and expansion. And Jennifer, you remember the kind of the MedPAC data prior to COVID around the use of telehealth, and it's still a problem. It's still reserved only for like, unfortunately, a certain type of Medicare beneficiary that really taps into it. But what I've seen in like kind of the different hats that I wear is this proliferation across the specialties. We're not talking just like, primary care doc. We're talking every single specialty now has these kind of, I'll call it, whether they're virtual options that are national neurology networks that participate in value-based care. I just talked to a cardiology national virtual kind of value-based care like initiative. And Belinda, Jennifer, guess what? They are gangbusters getting inbound from those same doctors, including like me, who's toyed with it myself. Like they're really kind of tapping into like that zeitgeist of what you both expressed. So I would encourage, if you're an individual and you're at an institution or you're not, and you're just out there and you're like kind of lost and you don't feel like you want to retire in the next 5 years, then there's been a lot of models, DPC, this, that, and the other. Those are all available to you. Trust me when I tell you that there are value-based care models that now will allow for you to do this virtually and also offer like incredible like value to a beneficiary. Autism, I've been seeing women's health. The things I have seen, some of them are highly publicized, MIDI, this, that, and the other. Those are a little more fee-for-service plays, kind of monthly, but there are value-based care efforts in every single specialty that I've now seen. And so if people want to, I'm happy to try. I have no money, I have no personal investment or money at stake in any of these. I've just been pleased with how they've been growing and how clinicians of all kinds have been trying to do it. The nice thing is that it offers a way to try it. You don't have to work 5 days a week, 7 days a week. You can try it at your own speed. If you're a specialist, they'll be even more flexible likely. And so it's encouraging. And most of them have like a total cost of care or some like desire to kind of show reduced readmissions for cardiology, for example, less use of stents, that type of thing. So less procedures, and patients like it. So it's convenient, you don't have to pay for parking. I always joke that the biggest pain in the ass to go to the doctor is parking. So, it's the biggest problem. Patients and
Well,
doctors, parking.
Well, we're now at the end, and Kavita, I want to thank you so much. And we got a ton of questions, which I think we answered some of them, but there was many. Unfortunately, we ran out of time. But again, Jennifer and I want to thank all of you for participating in this, and most of all, thank you for our guest, Dr. Kavita Patel. And next month, we're going to have another emerging trend and waiting to have her get approval, the official approvals to be on it, but it will be a really, really, again, exciting emerging trend. So again, thank you, Kavita.
Thanks for having me, guys. Take care. Have a great day.